Good afternoon. My name is Tracey Goodman, and I'm with WHO's immunization program based at headquarters in Geneva, Switzerland. And the topic of my presentation today is the implementation of maternal immunization programs. I'd like to begin by declaring that I have no conflict of interest. This is the outline of my presentation. I'm going to start by describing some high-level global context and refresh on WHO's guidance and the progress that we've been making. And then I'm going to talk a little bit about some of the work that we've been supporting and then move into the challenges of maternal immunization implementation in low and middle income countries and conclude with some forward-looking comments. For WHO and its international immunization partners, the starting point for maternal immunization really is the Sustainable Development Goals and SDG 3 in particular. That is the ensuring healthy lives and promoting well-being for all ages. And it's this target of reducing neonatal mortality to at least 12 per 1,000 live births, which is most directly relevant to maternal immunization because we're hoping that that will be a potential intervention to help achieve these targets. On the map here, you can see that neonatal mortality globally is still well above 12 per 1,000 live births in many, many countries. The dark green colors show where the mortality is above 12. And you'll see that this is mostly in the low and middle income countries, particularly in Africa and Southeast Asia. To align with the SDGs, you may not have heard yet that there is a new global strategy for immunization called Immunization Agenda 2030, or IA 2030 for short. And what's new about this global strategy, and we've had previous global immunization strategies, but this is the most recent, is its focus on life course, vaccination across the life course, rather than just on childhood. And with the attempt to realize that the benefits of vaccines, new vaccines should reach all, and that these should be delivered in a way which is using a primary healthcare approach. So this context is very supportive for maternal immunization. This slide illustrates the WHO recommended vaccines across the life course. And as I mentioned, we previously focused predominantly on the infant schedule. There are a lot of vaccines that need to be delivered then, and that was the emphasis, and a lot of success has been achieved. And now we're bridging out both directions to the pregnant and newborn target groups and also to older age groups with boosters and adult vaccination. And as mentioned, these need to be done in an integrated way. So this life course opportunity does allow for more integration. And this slide illustrates the many other important health interventions that could be combined with vaccination. And that provides an opportunity to work with other programs and deliver a package of services across the life course. Maternal immunization fits very nicely into this context. Because it potentially can have a very big impact on the neonatal mortality. And it also, in and of itself, requires an integrated approach by working through antenatal care services. And vaccination then becomes part of this continuum of care for the mother and child. In 2016, WHO issued new policy recommendations, moving from 4 ANC contacts to 8. This is the guidance that I'm showing you here. And many of those visits are now in the later third trimester of pregnancy. This doubling of the number of ANC contacts is quite a challenge because most of the world's pregnancies are in the countries with the low and middle income countries, which have the weaker health systems, and are also the countries, obviously, that I showed on the slide, the map previously, have the highest neonatal mortality rates. A lot of progress is being, however, made in antenatal care. The latest data we have here on services, coverage of services, is 2019. And it shows that only 60% of the world's women are being reached with at least 4 contacts antenatal care during their pregnant. There's huge disparities. And you can see that while there's good progress in Europe and America, Africa, Southeast Asia, and the Eastern Mediterranean, those main geographic blocks, are lagging behind with rates of 4 antenatal care visits of around 55%. So there's quite a bit of work to be done in, while things are improving, there's more work to be done. WHO has been working steadily for the past 3 years to advance maternal immunization, and we're taking a broad approach. And I wanted to speak just for a moment and give you a flavor for some of the work that we've been doing. Starting from the bottom of this slide, tells you a bit about the pipeline development work that we've been doing, particularly on RSV vaccine and Group B strep that we heard a lot about in the previous presentation. But we have a pipeline, an area of work that's helping to document the disease burden, make cases and try to secure future funding, looking at monitoring of the trials to see when the evidence is ready to be able to issue global recommendations on this. But in the background, and no less important, is our work that we've been doing on sort of preparing this platform. And I've shown here some illustrative examples of the type of work that we've been doing. A lot of this is focused on the safety of immunization during pregnancy, which is a particular concern. And through our Global Advisory Committee on Vaccine Safety, we've done a review of the evidence, even looking at issues and holding consultations on the ethics around vaccination in pregnant women, supporting some work on implementation of safety monitoring, and then a big initiative, which I'll tell you about later, on implementation of maternal immunization. This is the MIAXA report. So quite a comprehensive approach that we've been tackling. I want to turn my attention now to just describing at quite a high level some of the challenges that we are facing with the implementation of maternal immunization. And the first one is decision making. Many countries have weak decision-making processes for immunization generally. And these are doubly challenged for maternal immunization when awareness of the public health problem of diseases like RSV and GBS is quite low. They're just not well known there. So pretty hard to be advocating for the introduction of new vaccines when there isn't even a perception that the disease is a problem. So a lot of work needs to be done in advocacy and awareness raising. But there are other challenges around decision making. Many countries still haven't, there's a large pipeline of new vaccines, and they're competing in priorities. And it's very difficult for a decision making body in a country to be able to decide what should be introduced next when you can't afford, your health budget is not big enough to be able to accommodate all of the things that you might want to do. And so WHO has been working with the global, has a network for national immunization technical advisory groups to help strengthen their capacities to review the evidence and make informed decisions about what new vaccines to introduce next. And a lot of support will be needed as we move more and more into this maternal immunization to strengthen these mechanisms. That being said, we shouldn't forget that we have an excellent success story in maternal immunization, and that's tetanus toxoid has been a huge global success. And neonatal tetanus rates have just plummeted since the program was started and since tetanus toxoid was introduced in the early 1980s. This graphic shows, the bars show the decline in neonatal tetanus cases, and the solid or the dotted blue line shows the increase in coverage of pregnant women receiving 2 or more doses of tetanus toxoid vaccine. And you can see that over those years, we have achieved a 96% decrease in neonatal tetanus, which is really truly a remarkable accomplishment. And in order to be able to build on this platform from tetanus, we have done a a very large, extensive study over 5 years, looking at how these programs are working. And this slide shows you the report. It is so much there that I can't really cover it today in this short presentation, but it's also been published in Vaccine. And just a short summary is that there are many different models across different countries, not surprisingly. We do see good collaboration between ANC and EPI programs, but this may be variable depending on the mix of who does what, and the roles and responsibilities can be quite different from country to country. And the idea of being able to integrate services is also not a one-size-fits-all recipe that changes from country to country. We do see that there are shortcomings in the health system where there's not always enough health workforce and the availability is not there, and then some confusion over roles and responsibilities. Some of the challenges are around record keeping and the linkage of maternal and child health records, and a very strong message that was coming out from this review, which was involved 11 different countries and many more countries on surveys and telephone interviews, is that the safety and the adverse events following immunization reporting and surveillance systems really are important for maternal immunization. So there are a lot of operational and logistical factors involved in the implementation of maternal immunization, and the new vaccines are going to create even different new challenges that we need to overcome. In particular is this window of timing when the vaccines need to be given. Tetanus toxoid can be given ideally anytime during the pregnancy, but at least 2 weeks before the delivery. Some of the new maternal vaccines need to be given in a narrower window, late in the second or third trimester. And we really are lacking information on how women are accessing ANC services, at what week of pregnancy do they come. We believe that their evidence that we have seems to indicate that they come earlier in the pregnancy and then sort of drop out. And we also don't have very good knowledge on how the gestational age can be estimated in low-resourced clinics. And while there are efforts to scale up ultrasound, this will take some time. And then there are some very practical issues about the optimal vial size of the vaccine to reduce wastage, and particularly when these are costly vaccines, in order to not overextend the cold chain capacity. Is it better to have a multi-dose vial or a single-dose vial? There's trade-offs with both of those. So there's a need for implementation research in order to inform these discussions and decisions. Another area which efforts are going to be needed is focusing on acceptance and demand. In this internet age, information unfortunately travels very rapidly, and rumors do as well. And it cannot be assured just because new vaccines are available that pregnant women will be willing and accepting of them, and no matter how much evidence we have on the benefits. So this is going to need deep social behavioral science approaches to overcome these obstacles, and making sure that there are very tailored approaches to the new vaccine introduction. We have some experience with this with seasonal influenza. And I've borrowed from some slides that were used in a meeting that we had last year on GBS vaccine. And there are many factors that will believed to affect acceptance and uptake of vaccination during pregnancy. These include, individual and social influences, the particular characteristics of the vaccine, and contextual areas. So individuals' trust in the health system, previous past experiences, the role of a spouse and women's decision-making in being able to access the services, even literacy rates, all of these things need to be considered in making sure that we do have strong acceptance and uptake of vaccination during pregnancy. So that it's obvious that the acceptance and the demand for the vaccines is going to require a combination of interventions to improve the uptake. And this will also touch on training for health workers to make sure that their quality of their services and their conversations, their interpersonal skills with pregnant women are very convincing. There will be need to work with the social networks and communities to have peer-to-peer conversations that are well informed, and then there will be the sort of how-to things, having reminders if the maternal immunization requires more than one dose, you need to know when to come back for your next dose and so on, and there are many different ways that will be required to be implemented to ensure that this works smoothly. Final thing I want to talk about is an implementation challenge is really monitoring, and this has two domains. The first is the monitoring of maternal immunization safety. Once a new maternal immunization vaccine is introduced, there is a need to have a very strong safety monitoring system in place. And this presents a number of challenges because in low and middle income countries, these systems are not necessarily as strong and robust as we would like to see them. They are developing for the childhood immunization program, but we do still have some areas that need development for pregnancy. We don't have good registration of things even as births. The number of pregnant women that don't access services is also not well known. Health workers are not necessarily informed on the adverse events that might be common in pregnancy after immunization, and we do need surveillance to be able to strengthen and assure that the system is working safely. WHO has been working to establish this and learn from how to go about improving the safety for maternal immunization. WHO has a multi-country collaboration in this area. And this slide just shows you the sites around the world, and I give a reference to one of the papers. But this is a project very interestingly exploring the use of standard definitions of conditions and trying to get a handle on the background rates of these things, and so that these can be used to develop the platforms for safety surveillance in other countries going forward when we do have new vaccines. The other aspect that I want to touch on about monitoring is really the recording aspect, and the recording the number of the doses that have been received or given to pregnant women. From tetanus, the tetanus experience that I spoke about earlier, we've learned that it's quite difficult to keep track of the number of doses that women have had in subsequent pregnancies, and low and middle income countries are often relying on paper-based systems for this recording. And here I show an example of a mother and child health card from Kenya, which is a very nice example, or something that we call a home-based record. But in fact is ideal, but from studies, again, I show a publication here, we know that producing some of these cards is expensive, so they often are subject to frequent stockouts and are not available. And if you don't have a card, then health workers are very ingenious and resourceful and create the sort of handwritten slips of things that you should see in the middle of this slide. But often cost-cutting measures and so on require that the cards are produced on materials that are not so durable, and so they may not last if you're caught in a rain shower. And they're quite time-consuming for health workers also. Paper-based systems really do require a lot of efforts from the health workers through copying things from the home-based record into a register and so on. And we also hear reports of these sort of systems can create inequities, because if a card is lost, it may not really truly be lost by a pregnant woman. It may just have disintegrated, but then they're charged to pay for it again, and this can create a disincentive for accessing services. So while there's a hope that many countries will move towards electronic registers for recording doses, we're not there yet, and we do have to rely on these paper-based systems. So in summary, I've provided a snapshot, I think, of the implementation challenges for maternal immunization. I think there are a lot of positives. We do have a high level of global support and commitment for life course vaccination, and maternal immunization would definitely be part of that. We have many decades of experience with maternal immunization from the tetanus toxoid vaccination program, and that serves as a strong foundation for us to move forward with. ANC access and use is improving, but still needs strengthening. And importantly, we do have a bit of time before the new vaccines, fortunately, will be on our doorstep, and that we have a number of collaborative efforts that are working to ensure that we will be ready. Thank you.